All right, let's kick off the final session, which should be interactive. And the first panel discussion will be moderated by my wonderful colleague, Yanghee Woo from City of Hope. And go ahead and kick this off, Yanghee.
Great. Thanks, Juha. So I am so humbled to be here. And usually I don't get too nervous before a talk that I love to give or discuss. But just hearing all the presentations and the expertise in the room, it is truly humbling. And just to share, and I'm grateful to Juha and Rob and all of CARE for giving this opportunity and this platform for us to discuss and talk about gastric cancer prevention, early detection. Juha, I don't know if you remember, in 2019, you called and you were talking about the stomach cancer task force. And I was a little bit reluctant to do the same things that we were doing for the past, so many years. And Juha inspired me saying that we're going to make it different and we're going to make an impact and we're going to get all of these people together. And initially I was a little skeptical, but 6 years later, 5 years later, I'm no longer skeptical. And I think part of, other than the science and the trials and the evidence that we really need, there's another arm, I think, that is really important when we're getting screening programs, early detection, which is education and patient advocacy and sort of moving through policy. So everyone should know November is Stomach Cancer Awareness Month. And I'm not sitting behind the podium because I'm a little too short and I can't really see all of you guys. So I'm going to hang out here and look at the screen together. So I have summer students that come and do this summer program. They're high school students and college students at City of Hope, and they want to become cancer scientists or doctors. Lauren was one of them. And one thing that we learned during the time that Lauren Kim was with us for the summer, there's 4 of you, right? And one of the projects essentially asked the community, your own community, do you know anything about stomach cancer? And essentially 80% said they don't know anything about stomach cancer. And like Dr. Kim didn't know much about stomach cancer until he was diagnosed with stomach cancer, I think number one priority for all of us is awareness. So not just in November, but throughout the year. And I want to make some bold statements, and I don't know if they're evidence-based or through our hearts, but we know deaths due to gastric cancer are unacceptable. If we know we can cure it, we can prevent it, we just don't have the strategy right for US, but it's just not acceptable. And I'm not sure that any of the strategies that we're looking at right now through age, other than the fact that Tae was a Korean American male, I'm not sure we would have caught this early because he was 38 years old, I think, when he was diagnosed, and then he was diagnosed with stage 4. And he had a very, very difficult time getting any kind of treatment because people were just not aware that he could actually be at risk of stomach cancer. So I am very grateful to Juha and Rob and the CARE team for giving this opportunity to create a gastric cancer disparities initiative. We're at 2024, but we've been working together since 19, and you guys are all part of this from 2019, 2000, I think, was it 2020, 20 and 22, and now 24. It's the third one. And essentially, throughout the year, not just today, but we meet and we talk about how to address gastric cancer disparities in high-risk populations. And talking about policy is in terms of health equity for all Americans. And our goal is eliminate deaths due to gastric cancer. And here all of you guys have provided evidence and strategies for that. So the growing impact throughout the years, this is the third conference, and I think we're just getting better, and achievements have been pretty good. And we are empowered by what I believe is our collaboration, not individual efforts that's been going on for a long time, but that we're able to put all of this together, all of you in the room, sharing this information. And if you're not up there, please send me your logo, and I make sure that next time we put it up there. And it's international, not just national, as we saw today of all the people. And it's like a comprehensive approach. And if you take one of these out, I think it won't be successful. So science and research, we talked about a lot. The guidelines, it seems like, the Gastro AGA is leading the pack on this, but what guidelines can we really get? One of the patient advocates actually said, where are the guidelines? Patients are asking for guidelines. And I think we're getting there. Community engagement is going to be very important in partnership. Awareness, education, and understanding. And I think even if we had a guideline and a screening program today, it would fail, like the early colon cancer screening in certain populations, like Asians and Hispanics and Blacks, who don't actually get that screening, even if the guidelines exist. So community engagement, advocacy, policy, of course, funding to do our trials, I think is going to be is key. And through the Gastric Cancer Disparities Initiative, I can sort of put this into perspective and why I stay engaged. So if you disagree, just say you disagree, and then it won't be like a statement but a question. But gastric cancer is diagnosed in late stages and outcomes are poor in the United States. This is a fact. Rare cancer in the general US population, gastric cancer is not a rare cancer in ethnic Americans. I think all of you have presented data, so I took all the slides out with evidence. I'm just gonna make statements, and if it's wrong, you should dispute it. Gastric cancer is the leading or one of the leading causes of cancer disparity and health inequity in the United States. And I think this is also a fact. H. pylori testing and endoscopic screening in high-risk populations can be cost-effective, effective, and save lives. Okay, as long as I get a nod. Gastric cancer prevention and early detection efforts align with national initiatives from the NCI. Efforts in gastric cancer align. We're not doing this alone because the National Cancer Institute already stated that these are the things that we want to do to eliminate cancer deaths by 50%, right? So gastric cancer deaths should be eliminated by at least 50%, if I read this right. Not just breast cancer, colon cancer, because that would be equity, right? So eliminate inequities. Reasons for cancer disparities are complex. Inequities are also systematic, avoidable, unfair differences. And these are some things that I think we need to keep in mind when we make our strategies, because if we don't address these, no matter how beautiful a plan for screening we have, it will not affect our communities. So what are the barriers to prevention and early detection? Hidden disparities. We heard that if you're an immigrant from a different country, you speak a language other than English, then your likelihood of gastric cancer is twice as much, even more than that. But the issue is that if you speak a different language, getting into the health system to get care is even that much more difficult. And so this is a study that audited 144 hospitals across 12 demographically diverse states. Essentially what they did, they had people speak, I think, Mandarin, Mandarin, Spanish, and English. And if you spoke Mandarin and Spanish, you really didn't get to the next level of care compared to if you look at that little bar graph there. I think this is very striking and it's real. So at City of Hope, about 70% of gastric cancer patients are not non-Hispanic white. And more than 50% do not speak English. So there is a huge effort that needs to be made to ensure that whatever policies and programs that we have, that we're language appropriate. Discrimination is also a major barrier to receiving health care. And this is just the AACR data saying like individuals who feel discriminated against when they try to get cancer care. And obviously, ethnicity plays a part of this and something to think about as well. So cancer screening. So you could come up with this, you get all the scientists in the room, epidemiologists, you guys come up with this beautiful plan. And I think we need to be aware that race, ethnicity, household income, education, health coverage, the social determinants of health, that's going to keep our patients. And many of our gastric cancer patients fall into this. Those who are disparately affected fall into this category, and we really need to be aware. So our gastric cancer disparities initiatives policy progress, I think Juha mentioned, and Rob may have we have submitted nominations for primary and secondary prevention to the USPSTF, and this is something I'm going to urge you to do. I heard from others in at City of Hope was doing this for like Lynch syndrome. They said the more letters and nominations they get, the more likely that they will consider it. So what happened? Of those, we got a letter saying this USPSTF sent a letter, so we made some progress, that this topic has been added to the list of preventative services topic under active consideration. So they'll think about it. It's one step forward, small step forward, and I wouldn't have done it if I wasn't part of GCDI and hadn't gotten support from Rob, who sent in the letters from Stanford. So gained support. So in the back, we met with Judy Chu and Nisha, and this was a big effort by Lee and the care team here. And so then, thanks to Aki Smith, I think you're going to show us this too. But ask your Congress to take action. I love this. I took it off the internet. But essentially, achieve legislation acknowledging gastric cancer to be important. So as science and medicine move the needle in that realm, I think it would be good to get awareness in our public policy world. And then thanks to Aki Smith and Hope for Stomach Cancer again, President Biden acknowledged support for Stomach Cancer Awareness Month with a very specific letter. And it sort of puts it into perspective of the Moonshot National Cancer Institute efforts. So we don't want to be left out, when you're a minority or you're a very small number of people, and gastric cancer is an uncommon cancer overall, it's easy to leave us out. But I think we're getting recognition that we should not be left out, and this is very important for us. So what are some of the real-life challenges? Everyone said, well, the next step is to have a trial. So what's the trial? I heard Dr. In has proposed a opportunity study for DOD. I hope that it will get funded. And I just looked up the data. So Rob, I think a couple years ago we said it was like 0.16%, right? The NCI data, it was 10 million. Yeah, so in 2022, it became 16 million, but it's 0.24% or something like that. And Dr. Kim, that's like less than inflation, you said, right? So I don't know if we made that much progress, but hopefully your DOD grant will be funded. So we do have an early study at City of Hope, and this is taking into account all the things that we were talking about to do a feasibility study. It's not big enough. I went to my epidemiologist and asked them if we wanted to do a randomized controlled trial to prove that gastric cancer screening is gonna save lives. She said, well, good luck, 20 years, and $20 million and 25,000 people here, randomized to one the other. And I said, well, I don't know. I'm hoping in 10 years I'll be retired, so I have to do another study. And so the Curate Rare Cancers Research Foundation gave us a small funding, about $250,000, to do a pilot study to talk about feasibility, not necessarily to find early cancer or H. pylori, but to see if the patients would actually come. And essentially, we'll do website, MD referral, community leader referral, self-referral. You'll be risk assessed. We'll risk assess you. We'll determine whether we'll do a questionnaire. We'll do you see me or one of the GI guys, and we're going to figure out if you're high risk, defined by relative risk, figured out by one of our biostatisticians. If you get 12 points, then you're at high risk, including Korean Americans had the highest score, and et cetera, family history, all the stuff that we all know. And then you're going to get H. pylori tested, get a CBC. You're going to come see one of the doctors, and then you will be offered an upper endoscopy if you're high risk. A whole bunch of questionnaires were created, your scores were created, and endoscopic procedure, Sydney protocol. So it's a multidisciplinary effort. We got all of our GI guys to agree to do this and report it like here, but we didn't talk about like intestinal metaplasia, all the subspecialties, subgroups, just that whether it's complete or incomplete subtype. And then this is the study calendar. So this, and we made our website. We did our patient, we're doing like every 2 months, we're going out into the community, talking to community leaders. This was with like a whole diverse group of community leaders in Orange County. And in 2 weeks, we'll meet with the NCAACP. And then what happened? So it's been open for 6 months. And we had like 20 people really interested. And then 1 person went to get an upper endoscopy. And 3 patients enrolled. It's really tough to get this. And one of the major reasons that patients aren't coming, they have to come 3 times. You have to come to get registered. You have to come to get the blood test. You have to come to get your results in the endoscopy. And so this 3 time in the community is very difficult to do. So just something to consider. So I'm just going to do call to action real quickly, and I'm going to leave actually the real call to action to Kathy. But it's very simple, I think, that we continue our work, share our knowledge. I'd urge you to join us in sending the USPSTF to make some recommendations for primary and secondary prevention, sign letters of support with new legislation for increasing funding for gastric cancer, and perhaps as we prepare to get these recommendations into guidelines, we should have a task force about how are we going to engage our community and the policy leaders to be able to make it an effective screening program. That's it. Oh, thank you for your attention. I'm actually a surgeon who does robotic surgery mostly, so I depend on our gastroenterologist to talk about the screening. Any questions?